Hello everyone, welcome to Pediatrics by Dr. Anand. This is the Unacademy NEET PG form and today we are talking about cardiology. Today's topic of choice, we're going to talk about very important few conditions known as TGA, TAPVC or tricuspid atresia. My name is Dr. Anand. Platform is today. Today is a very beautiful day and what do you call it? In this segment, we're going to talk about very important, simple questions. For the newcomers who have joined Unacademy, first of all, let's congratulate to the students who worked really hard. Our FMG December 2021 batch students, every single student have worked really hard in the in their upcoming exams, and now they have got this wonderful rank, which is amazing. Now I want you all to participate in the exams and give your best shot. And also in the Unacademy for everyone, we have something known as plus subscription and something known as iconic subscription. In the plus subscription of the Unacademy, you get the access to all our live and recorded classes. You get to study from the best of the best educators all over the India. You get to participate in various live tests and quizzes, and also you can watch the videos on your laptop, on your basically on your Android devices and also on your iOS ones. Okay, this is the plus subscription, whereas iconic subscription is amazing, where you get the Unacademy platform and also the prep ladder subscription. Hello Rashi, hi Osama. All the clinical notes, video lectures, question bank, rapid revision, and treasure notes are the iconic subscription. So means we have like something known as plus subscription and something known as iconic subscription. And being an MBBS student, once sometimes it becomes little financially difficult to buy a pack. So if you use this code, it will be little financially comfortable for you if you want to, have any kind of access to all our recorded sessions from A to Z of all the faculties and all the subjects. And also we have made this wonderful batch of Focus FMG 2022 comprehensive batch and Target NEET PG 2022 MCQ discussion batch. So I hope you guys are a part of it, because we have made this a batch with a lot of hard work, and every single student is really working hard for that. We have already made this free test calendar for the medical PG students. It's a very wonderful, like in my time also, I remember I always used to give lot of MCQs test, lot of tests, because test will tell us our rank, test will tell us where are we standing. So I would recommend, it's good to give a lot of free tests in this medical PG prep, and I think it'll be good if you guys try to participate in the free test calendar. Hello Sama, hi Zainab, hi Rachna, hi Sai. Hello amazing people. सुबह के 9:30 बजे हैं और सब लोग आ गए हैं. किसी की नींद तो नहीं खराब की मैंने. मैं आराम से उठा, अब आई एम लिटिल फ्रेश. I hope you guys are okay. Good morning, everyone. Hanji. Today's topic of choice, we're gonna talk about today's the topic of choice is cardiology. The subtopic is TGA, TAPVC, truncus arteriosus, and tricuspid atresia. We're gonna talk about few important points of these conditions. It's a very important class. This session will be spoken in English and Hindi language. आज की क्लास में हम ये चार important topics के बारे में बात करेंगे. TGA, TAPVC, truncus arteriosus, and tricuspid atresia. And before starting any session, always we have this wonderful motivating quote. So today's beautiful quote is, you are the writer of your own story. You are the writer of your own story. So write something good every day. You are the writer of your own story. So write something good every day. You can be negative all the time. You can be stressful all the time. You can be positive all the time. You can be happy all the time. So, we all have problems in life. We all have problems in life. No one's life is free of, problems. I hope you all agree with me. So all we can try do is try to be happy, try to stay positive, try to stay calm, and try to have a focus in life. A vision in life is everything. You need to have a vision. A vision, without a vision, if you're working hard, it's hopeless. Then you are nowhere. Okay. So you are the writer of your own story. So write something good every day. Try to study, try to do as much as possible and in a very wonderful manner. Don't cram, try to understand the concept. Okay. रचना, ज़ैनब, साइनी, ओसामा, राशि. ठीक है, आज की बहुत ही सुंदर दिन की शुरुआत करते हैं. और यस, द प्रीवियस होमवर्क, पैनकेक, वन ऑफ आवर स्टूडेंट, ऑलवेज शी इज़ अ वेरी वंडरफुल स्टूडेंट, ऑलवेज डूइंग द होमवर्क्स. द प्रीवियस होमवर्क आई हैड आस्क्ड यू क्वेश्चन नंबर 1, DQ and IQ. This was the question I asked in the previous classes. So developmental quotient and intelligent question. We all know that developmental quotient is equal to developmental age upon actual age into 100. Developmental age upon actual age into 100, and IQ is equal to mental age upon chronological age into 100. These two are the simple important formulas. In every class, I'll be asking you a lot of homeworks. In every end of the class, I'll give you homeworks and you try to read at home and come back to me in the next class. So DQ and IQ formulas are important. DQ is equal to developmental quotient and IQ is equal to intelligent quotient. Developmental quotient is equal to developmental age upon actual age into 100, and intelligent quotient is equal to mental age upon chronological age into 100. These are very important formulas. They have come in exams and we must know them. For example, DQ, we had a MCQ. Let's see if you can answer. At what years can a child of DQ of 50 can do the following? At what years can a child of DQ of 50 can do the following? Following matlab this. Number one, what is this boy doing? Anyone? Can anyone comment? What is this boy doing? Yes, very good. This boy is riding a tricycle, right? Normally, when does a baby ride a tricycle? 3 years, right? A 3 year, three, how will I remember? Try means three. A 3 year old baby, yes, very good. Osama, Rachna, very good. So a 3-year-old baby will ride a tricycle. So the question is, at what years can a child of DQ 50, of the developmental quotient of 50, do the following? Normally, my developmental quotient should be 100, right? If a normal child who is 3-year-old who will ride a tricycle, his DQ should be 100. Okay, his DQ should be 100. But my question is, at what years can a child of DQ of 50 can do the following? Okay, means a 3-year-old well, 3-year-old ride will we can ride a tricycle, but his DQ should be 100. But if a child DQ is 50, then what's the age? So we all know that developmental quotient is equal to a developmental age upon actual age into 100. So DQ is 50, it's what given in the question. Developmental age of this child normally should be 3 years, right? The baby is riding a tricycle, right? 3 years. But I need to calculate the actual age. Actual age. So this is the formula, and according to this formula, the actual age is coming is nothing but 6 years. The actual age is coming is 6 years, ये एग्जैक्टली 6 होगा. जब डबल भी कर सकते हो ना, नॉर्मली DQ 100 होना चाहिए and a baby should ride a tricycle by 3 years. If someone's DQ is 50, means that work he will do at the double age. So instead of riding a tricycle at 3 years, he will ride a tricycle at 6 years. Okay, in general also you should understand like that, and in the formula wise also you should understand like that. Understood? So this was DQ and IQ. Very important homework question we had given, and good that if you guys have really read it. Very good. Good. And yeah, in this question, see, at what years can a child of DQ of 100 can do the following? A DQ of 100 is normal, and the baby can ride a tricycle by 3 years. So in this question, if the DQ is 100, then of course a 3-year-old can ride a tricycle. If the DQ is 50, means it will take double time for the baby to get one milestone. So that's how the answer is. Understood? I hope you guys have understood. Yes, very good, Devina. The more you try to participate, the more it will be amazing. One more question I had given homework in the last class. You remember I told you, if you want to keep the PDA open, if you want to keep my patent ductus arteriosus open, give me prostaglandin PGE1 analog, that is L-prostadil, right? And if you want to close my patent ductus arteriosus, you give me indomethacin or ibuprofen. Okay, indomethacin and ibuprofen, right? My question homework which I gave you was, what is the triad of congenital rubella syndrome? Like, after teaching patent ductus arteriosus, I suddenly jumped to congenital rubella syndrome. So does anyone remember what is the triad of congenital rubella syndrome? Anyone? Yes. So we have a torch profile, right? Torch profile. T for, what is T for? T for toxoplasmosis. O for others. R for rubella. C for cytomegalovirus, and H for herpes, right? Yeah, exactly. So I'm asking the triad of congenital rubella syndrome. The triad of congenital rubella syndrome is nothing but cafe coffee day, CCD. Okay, the number one, congenital heart disease. The congenital rubella syndrome babies will have a congenital heart disease, they will have cataract, and they will have deafness. They will have deafness. Yes or no? We have done this in the previous classes also. The congenital rubella syndrome triad is cafe coffee day, congenital heart disease, cataract, and deafness. And which congenital heart disease is very common? The most common congenital heart disease in congenital rubella syndrome is patent ductus arteriosus. We have to link and study, then only we'll able to cover the syllabus. So once we cover patent ductus arteriosus full topic, remember in the yesterday's class we have done patent ductus arteriosus, left to right shunt, acyanotic congenital heart disease, yes or no? So yes, very good. So, what you called the triad of congenital rubella syndrome is cafe coffee day. C for congenital heart disease, C for cataract, and C for deafness. Deafness, which one? Yes, you're right. Kind of a yeah, exactly. Sensory neural hearing loss, yes. And what you called there are three important questions in congenital rubella. Which is the most common congenital heart disease in congenital rubella syndrome? The answer is patent ductus arteriosus. Which is the most common manifestation in cafe coffee day? Which is the most common manifestation a baby can get? The answer is deafness. Deafness is the most common manifestation of congenital rubella syndrome. As everyone understood this much, please put a like button. Please say a comment yes that you have understood so that we can move further. इतना समझ में आ गया? इतनी सी बातों में ही हमने बहुत सारे questions खड़े खड़े cover कर लिए. In this such a small talk we have covered multiple questions actually. So done? Yeah, very good. समझ में आ गया? Very good Osama Sheikh. Very good. One of our dear student Rachna. Perfect. चलो आगे बढ़ते हैं. Yes. So today's topic of choice is nothing but TGA. So I have to explain TGA properly and I have to tell multiple points regarding TGA. Okay. Number one, TGA. What is TGA? We all know that TGA is what is the full form of TGA? TGA is nothing but transposition of great arteries. Okay. Now please be with me. If you need to, I need your brains to be here in this class. Transposition of great arteries. This is known as TGA. Transposition of great arteries. Okay, number one. Number two, what happened? Which great arteries are we talking about? If we make a normal heart diagram like this, a beautiful heart, and we have this, what you call, normally here should be pulmonary artery, and here we have is aorta. Yes or no? We have right atrium, right ventricle. In between, you have a tricuspid valve, and we have left atrium, left ventricle, and we have a mitral valve, right? So here we have a pulmonary artery, and normally here we have aorta. Yes or no? Right, Hanji? Very good, Sayani, Osama, and Mona Lisa, and what he called Rachna. Very good. So the topic is transposition of great arteries. Transposition of great arteries. Transposition of the great arteries. Which great artery are we talking about? So pulmonary artery and aorta. So what happens in the transposition of great arteries? Nothing, very easy. Instead of origin of pulmonary artery, like this thing becomes aorta and this thing becomes pulmonary artery. Okay, that is the first point. In the transposition of great arteries, there is a transposition. जहाँ से पल्मोनरी आर्टरी आती है वहाँ एओर्टा अटैच हो जाता है और जहाँ से एओर्टा आता है वहाँ पल्मोनरी आर्टरी अटैच हो जाती है. ओके, फ्रॉम द पॉइंट वेयर द पल्मोनरी आर्टरी इज कमिंग एओर्टा विल get attached, and from the point where aorta is coming pulmonary artery will get attached. Now how the circulation will takes place? The deoxygenated blood which enters my superior vena cava, where does it go? It goes to the right atrium. Normally, then this deoxygenated blood from right atrium, where does it go? It goes to the right ventricle. It goes to the right ventricle, and then this deoxygenated blood, where does it go? Normally, this deoxygenated blood should go to pulmonary artery, but in this case, what will happen? This deoxygenated blood will go to the aorta. It will go to the aorta, and this deoxygenated blood, which is coming from the superior vena cava, it is going to the aorta, and from the aorta normally where does it go? It supplies to the whole body. So it supplies to the whole body, right? And then this deoxygenated blood normally after supplying to the whole body, where does the blood go? The blood go back to the again superior vena cava and inferior vena cava, right? And then it enters the right side of the lung. So can we understand that deoxygenated blood is entering in my body and deoxygenated blood through the aorta is exiting my body? And once the deoxy blood exit my body, then again, kind of the whole deoxygenated blood, which is a natural process, that it enters the right side of the heart by superior vena cava and inferior vena cava. So deoxy blood only coming and deoxy blood only going, deoxy blood only coming and deoxy blood only going. Yes or no? Do you, can we appreciate this point? Yes or no? Yes, exactly. So so much of bad mix, like so much of bad blood going and bad blood in coming and blood only going, right? Number one, what will happen? The child will be fully cyanosis, yes or no? PGA is one of the cyanotic, the congenital heart disease. The most common cyanotic congenital heart disease at day one of life is TGA. Okay, the most common cyanotic congenital heart disease at day one of life is TGA. TGA is one of the cyanotic congenital hearts, and this much we should able to understand. Okay, perfect. Now let's move further. What happens on the left side of the heart? On the left side of the heart, normally what do we have? We have our lungs. The oxygenated blood basically it from the lungs, it enters into the left atrium with the help of pulmonary veins, yes or no? The normal mechanism of the purified blood or the oxygenated blood from the lungs, it starts and enters the left side left side of the heart, and it enters the left atrium. Then this oxygenated blood from the left atrium, it enters the left ventricle, right? Then this oxygenated blood from the left ventricle should be going to the aorta, but in this case, where it is going? It is going to the pulmonary artery. Yes or no? Because we are studying transposition of great arteries. So can we appreciate that this oxygenated blood from the left ventricle, it enters the pulmonary artery, and pulmonary artery, where it is attached to? Pulmonary artery is attached to the lungs normally, right? So again, once the oxygenated blood from the pulmonary artery goes to the lungs, what happens in the lungs? Purification takes place, and then again the purified blood from the pulmonary veins again entering into the left side of the heart. So can we understand that purified blood only is entering, purified blood only is going, and again purified blood only is entering the lung, and purified blood only is going. Are you understanding? Yes or no? Oxygenated blood only entering in the lungs, and oxygenated blood only coming out, like going into the left atrium, left ventricle, pulmonary artery, again the lungs, left atrium, left ventricle, pulmonary artery, again the lungs, right? So number one, at this point, in the right side of the heart, it is deoxy blood coming and going, and at the left side of the heart, it is the oxygenated blood coming and going. Yes or no? Can we understand this question, this point? Okay. This this is known as parallel circulation. This is known as parallel circulation. That is the first point. Okay. This is known as parallel circulation. Parallel. One side the deoxy blood is jumping here and there, and one side the oxygenated blood is jumping. There is no connection at all. This दोनों अलग अलग हिसाब किताब से घूम रहे हैं. This is known as parallel. Yeah, very good. This is known as parallel circulation. That is the first point. Now what happens? Now again, PG entrance question number one. In this parallel circulation, see, the baby will die. Okay, the baby will die because the most common, the baby will be fully cyanosed. Yes or no? Because deoxy blood entering the superior vena cava, right atrium, right ventricle, and directly going into aorta and supplying the whole body. Here, will the baby survive? Baby will not survive because there is all bad blood going here and there. Yes or no? Yes. So in this condition, if I open this channel, what is this channel which is between the pulmonary artery and the aorta? This is nothing but patent ductus arteriosus, PDA, right? Have you heard of PDA, patent ductus arteriosus? So if I open this channel, PDA, see, PDA opening or closing is in my hands, okay? PDA opening or closing is in my hands. I can give what you call same PG even analog L prostadil if I want to keep the PDA open. I can give ibuprofen if I want to keep the PDA open. So only PDA is in my hand. If I keep the PDA open in this scenario, what will happen? Basically, anyone, if I keep, will the opening of PDA will helpful for the baby? So what will happen? The oxygenated blood enters the left atrium, left ventricle. Then as PDA is a left to right shunt, the oxygenated blood from the PDA will enter into the right side of the heart, and there will be mixing of the blood, where the oxygenated blood will be mixing with the deoxy blood, and baby will get some chance of survival. The baby will get some chance of survival. Yes, exactly. So in this condition, number one, PDA, is PDA opening here helpful or not? Yes, sir, it is very helpful. Why? Because, sir, if you open the PDA, patent ductus arteriosus, sir, it is a left to right shunt. If you open this channel, the people will run from left to right only, because the left side of the heart has a higher pressure. So I can understand that once you open a PDA, the blood will jump from left to right. And if the people are jumping from left to right, it will be good, because right side of the heart has all the deoxy blood moving here and there and not helping the baby. Now if I open a PDA, the oxygenated blood will enters the right side of the heart, and it will become like, it will give a chance of survival to the baby. This much has everyone understood? Say yes or no, or you can put a nice heart if you or say a yes or a yes yes. Say that. Okay, anyone, what do you think? हाँ जी, समझ में आया या नहीं आया? राइट, ओसामा शेख, बहुत बढ़िया बता रहे हो। ठीक है, तो दैट्स व्हाई पीजी एंट्रेंस, हाँ जी, यस दीपक। तो गाइस, हैप्पी इंडियन आर्मी डे। सर जी, थैंक यू, थैंक यू। आपका मैसेज भी आया था मेरे को, मैं अभी क्लास के बाद आपको रिप्लाई भी करूंगा। एंड यस ब्रदर, यस, हैप्पी इंडियन आर्मी डे। God bless you, and you're working really hard and helping us all out. You're also like a frontline worker, you know. So thank you. Very nice. Okay, आगे बढ़ते हैं। आगे तो ये छोटा सा एक कोट आ गया। The beautiful quote: the price of for true inner happiness is zero. The price of true inner happiness is zero, but the price we pay seeking this happiness is immeasurable. Very beautiful quote. Again, I would like to thank Dr. Savan for this. One of my junior, he has sent me this quote. So the price for true inner happiness is zero. You don't need money to be happy. You don't have to go to London to be happy. You don't have to go to China to be happy. You can be really happy at your home, and it's a very wonderful feeling to be happy with no reason, you know. And the price for true inner happiness is zero. But the price we pay seeking this happiness is immeasurable. I have seen people saying that, you should go to that temple, God picture is there, and then you will feel, peaceful in your mind. You should go to China, you should go to Nepal, there's a big Lord Buddha statue, and that will give you happiness. You should go to Israel and do this and that. No, you don't have to go anywhere. You can be very happy at your home. You can be very happy with yourself having nothing. Can be just happy. Happiness is priceless, and it is not expensive, but we have made this mind that it is very expensive. The price for true inner happiness is zero, but the price we pay seeking this happiness is immeasurable. So coming to this, number one, transposition of great arteries. Is it a cyanotic or a acyanotic congenital heart? It is a cyanotic congenital heart. And why? I have told you in depth and detail why. Next very important thing, yes, now this is the exam question. Let's see. Hanji. Yes. Okay, who will tell me TGA is the most specific congenital heart disease in which condition? This is another beautiful exam question. Let's see if you can answer. Hanji. Yes, Zainab Akhtar is a new student and she's answering really well. Okay, Mona Lisa, yes, I noted, you're right. Yes. So Rashi Rastogi, yes, the baby, like if you don't operate in the case of TCA, the baby will expire. So that window period, I'll tell you, it will come in further slides, how much hours or days a baby will have, if you don't repair the TCA. So yes, exactly. Rachna is right. The most specific congenital heart disease in infant of diabetic mother is nothing but TGA. Infant of diabetic mother. Have we heard about this topic in the previous neonatology classes? We have very wonderfully for 1 hour. I have taken a class on infant of diabetic mother. If you are free, then later you can watch this free video in the Unacademy app. It will be helpful. Infant of diabetic mother, the most common congenital heart disease in infant of diabetic mother is the PSD, and the most specific is a TGA. These were very important exam questions. The most common congenital heart disease in infant of diabetic mother is a ventricular septal defect, and the most specific is the TGA. Again, we have to link and study. We are studying TGA. That's why it's my duty to tell you that the most specific congenital heart in infant of diabetic mother is a TGA. And remember, in infant of diabetic mother, the mother will be hyperglycemic. The mother will be hyperglycemic and the baby will be hypoglycemic. Okay, the mother will be hyperglycemic and the baby will be hypoglycemic. That also an extra point we must understand in this topic. Next. Yes, this part is over. Huh. Okay, now the extra points are of TGA. We have almost covered everything about TGA, but few points are left. I'll just cover it up very soon. TGA is associated with uncontrolled phenylketonuria in mother. It is just like a one-liner which we must understand. It has come in exam also. TGA is associated with uncontrolled phenylketonuria in mother. If a mother is having uncontrolled phenylketonuria, so TGA is associated with that, okay, with uncontrolled phenylketonuria in mother. Number one. Number two, yes, we all know that in the TGA, in the TGA, when four chambers are there, there is normal, there is normal to increase pulmonary blood flow. Yes or no? Here, like this part, this part in the TGA, this part was the what you called aorta, right? And this part was the pulmonary artery. So just remember, when the blood in the lungs, the oxygenated blood which was entering, so normally there is increase, normal to increase pulmonary blood flow in the TGA, but you will not see pulmonary venous hypertension. Pulmonary venous hypertension is not seen. Pulmonary venous hypertension matlab that, why pulmonary venous hypertension happens. Normally what happens, when too much of blood goes to one artery, that artery starts to getting close, okay. But in the case of TGA, it doesn't happen. You don't get a pulmonary venous hypertension, like you got you got don't get a pulmonary hypertension in a case of, what you call TGA. In general, you should know there is normal to increase pulmonary blood flow, that much we should know. But not a pulmonary hypertension. And TGA is common in males. TGA is common in male baby, okay. Yes. Now Rushkin procedure. Where do you see Rushkin procedure? Anyone? Anyone? Where? See, there is something known as Jettini procedure, Jettini repair, and something known as Rushkin procedure. There are two procedures we need to know. Okay. Where do you see Jettini repair? These all are exams question. Jettini repair we do in nothing but TGA. The one of the treatment of choice for what you called surgical treatment of choice for transposition of great arteries is nothing but Jettini repair. This I think everyone knows. We have done this also. Osama was mentioning in the comment section also. So in the transposition of great arteries, the surgical treatment of choice is Jettini repair. But I'll give you a toffee if anyone can tell me Rushkin procedure is done in what? So Rushkin procedure is done in the dextro TGA. There is some entity known as dextro TGA. So Rushkin procedure is done in the dextro TGA. Okay, just this one word we need to understand. Normal TGA, you will do what you call this our Jettini repair, whereas Rushkin procedure is done in DTGA. What is DTGA? Dextro TGA, that you should know. Okay, and what happens in the Jettini repair? This point also we need to understand. Now I'm showing you this one. Now see this. What is Jettini repair? Like students were asking. So if this is a normal four-chambered heart, and this is now in the TGA, this is my aorta, and this is my pulmonary artery, right? So now what happens? Normally, when the deoxygenated blood from the superior vena cava enters the right atrium, right? This is normal. Now, what I will do, and this is right ventricle, right? This is left atrium, this is left ventricle. I am telling you what is Jettini repair. Jettini repair. Okay, so what happen if I connect my superior vena cava, like the blood from the superior vena cava enters the right atrium. From the right atrium, I am connecting the right atrium to the left ventricle. So now listen very carefully. What will happen? Let me just change the pen color. So if I connect my right atrium with the left ventricle, so what happened? The oxygenated, like the deoxygenated blood enters the right atrium. Normally, the deoxygenated blood from the superior vena cava enters the right atrium. Now this deoxy blood will go to the left ventricle. Okay. From the left ventricle, now where the deoxy blood is going, it is going to the pulmonary artery. Yes or no? And where are the pulmonary artery are connected? They are connecting into the lungs. And what will happen? Purification will happen. Yes or no? Now, what will happen? This purified blood, this purified blood enters the, with the help of pulmonary veins, it enters the left atrium, right? Normally, this much you understood, right? Yeah. Now what will happen? Now the left atrium has been connected to the right ventricle. Just, yes, just imagine the left atrium is connected to the right ventricle. I have done this surgical procedure, okay? So what will happen here? The oxygenated blood, now from the left atrium, where it will go? It will go to the right ventricle. And this oxygenated blood, where it will go? It will go to the aorta and it will supply the whole body. Now, this is known as Jetany repair. This is known as Jetany repair. Okay, that you should know. Okay, yeah, this is known as like a arterial switch. It is a switch repair. It is a switch. मैंने switch दो switch घुमा दिया ना उल्टे. So this is known as switch repair. Okay, yeah, that you should know. Did you understand? Yes or no? So this is very important if you need to know about nothing but a surgical treatment of choice of what you called अपना of the TGA. समझ में आया कि नहीं आया? Yes, exactly. So there's a very beautiful slide and picture showing this one. Okay, done? Done. Okay, next question. I'm gonna समझ में आ गया? Put a yes button or a say put a like button or at least say a comment कि समझ में आ गया, ठीक है? Very good. I assume that सबको समझ में आ गया है. Let's move further. Okay, the next question is which is the most common congenital heart disease? Which is the most common congenital heart disease in cardiology? Anyone? Which is the most common congenital heart disease in the full cardiovascular system? Yes. So Rashi, Osama, Rachna, Devina, and Mona Lisa, people who are commenting and people who are participating, they have one chance more to clear to appear in exam. I'm very sure that these people definitely will get a good rank. People who are participating. Okay, that's why I always tell you participate, participate, participate. The most common congenital heart disease in my full cardiology is a ventricular septal defect. Yes, exactly. Very true. Which is the most common acyanotic congenital heart disease. So the most common is ये पर्दा हिलेगा. The most common acyanotic congenital heart disease in cardiology is a VSD. The most common acyanotic congenital heart disease in the cardiology is the VSD, and most common cyanotic congenital heart disease. The most common cyanotic congenital heart disease at day 1 of life is a TGA. Otherwise, it is a tetralogy of Fallot. ठीक है, very good. Osama, मैसेज डिलीट करने की ज़रूरत नहीं है. गलती करे मेरा भाई, तू मेरा भाई है, क्यों टेंशन ले रहा है? कुछ नहीं कहूँगा, कुछ नहीं बोलूँगा तेरे को अगर गलती करेगा तो. ठीक है, so that you should know. ठीक है, perfect. हाँ जी, this part is over. हाँ, so what happens, you know, like that's what in now can we understand these lines? Is there a complete separation of systemic and pulmonary circulation in TGA? Yes or no? Is there a complete separation of the systemic and also of the pulmonary circulation? So yes, it's very true, sir. Yes. So now survival depends on the mixing of the blood, and how the mixing of the blood will takes place if I open the PDA. Yes or no? The survival depends on the mixing of the blood, and mixing of the blood can only be happen once I open a patent ductus arteriosus. इस टॉपिक को इतनी अच्छे से पढ़ लो, इतने अच्छे से पढ़ लो कि कभी भी ना भूल पाओ. प्लीज रीड, if you're reading one topic, read it so beautifully and so depthly, so amazingly that you don't miss any point, right? So do you are we dependent on ductus arteriosus in TGA? Definitely. By mixing of blood only we have a chance of survival for the baby. Okay. That you should know. Okay, again very important question of what you call PG entrance exam. What is the X-ray finding of TGA? Everyone knows this answer. Egg on string appearance. Egg on string appearance, ande pe dhaga. This is the chest X-ray finding of the TGA. Okay, so let's revise. Where do you see boot shape heart? Anyone? Where do you see boot shape heart? Yes, boot shape heart is seen in tetralogy of Fallot. Where do you see box shape heart? Very good. Box shape heart, it is seen in Epstein anomaly. Very good. Where do you see water bottle shape heart? Water bottle shape heart or a money bag appearance? The answer is pericardial effusion. Very good. Pericardial effusion. Very good. So these are the things we must know. Okay. And where do you see? Okay. Where do you see shmoo sign? Shmoo sign. Shmoo. Shmoo sign. I showed you in the previous picture also. LVH, left ventricle hypertrophy. You see SHMO sign. Okay, left ventricle hypertrophy. So these, where do you see figure of 3 appearance and figure of 8 appearance? Figure of 3 appearance on X-ray, you see coarctation of aorta. Figure of 3 appearance on X-ray, you see coarctation of aorta. And where do you see figure of 8 appearance? Figure of 8 appearance you see in supracardiac TAPVC. Supracardiac TAPVC. What is TAPVC? Total anomalous pulmonary venous connection. Done. I assume we all know this much. Okay, very good, very good, everyone. Okay, okay, okay. Though this is very nice question. So always remember, dear, like what we are studying, like in a study in TGA, right? Like I want you to have every, point of view regarding TGA. This was the aorta and this was the pulmonary artery, right? In the case of TGA, right? The clinical features, of course, the baby will have cyanosis. The time of presentation depends on whether the ventricular septum is intact or VSD is present. Please remember, normally all these congenital defects are not isolated. Normally, these congenital defects are associated with some other defect also. Means in this topic, if you're studying TGA, the book is saying that it is very less likely for a baby to have a transposition of great arteries alone. Either the baby will have a transposition of great arteries with artery with VSD, TGA with ASD, TGA with PDA. Are you understanding? Because if you do a alone TGA to a baby, he will die on the spot. Like he'll die very, very fast, I would say. Not on the spot, but in very few hours he'll expire. So it's like, are you understanding? So that's what the time of presentation of clinical feature depends on whether the ventricular septum is intact or VSD is present. Means it is isolated TGA or it is a TGA with the VSD. TGA with VSD. Are you understanding? Yes. So now remember, patients with TGA with intact septum are cyanotic at birth. Of course, now this is the question one student was asking, that how many hours the baby will expire or what is the time duration. So again, if this is again our what you call aorta and this is our pulmonary artery, patient with TGA with intact septum, with septum matlab ye wala, all this ventricle atrial septum like a normal heart but only TGA. Patient with TGA with intact septum are cyanotic at birth. Of course, they are cyanotic at birth with congestive heart failure occurring at first week of life. So number one, if you have an isolated TGA, the baby will be showing you the symptoms of failure or the baby will be deteriorating within first week of life. So 1 week of life we still have. The baby will not die on the spot. Yes, the baby will not die within 1 day. The book says the congestive heart failure features happens in the first week of life in an isolated TGA. Number two, patient with TGA with VSD. Patient with TGA with VSD. So again, this is our what you called again our aorta. This is our pulmonary artery, but here there is a VSD also. So patient with TGA with VSD they will with mild cyanosis and CHF occurs in 6 to 8 weeks of life. 6 to 8 weeks of life, roughly around 1 to 2 months. Okay, around 2 months. So please remember, if the baby was isolated TGA, he will show you the symptoms of failure within first week of life. And remember, like in the babies having TGA with VSD, of course, it will show you the symptom within 2 months. The CHF will occur in 6 to 8 weeks. Even some books says 4 to 10 weeks also, right? That's what, yeah, exactly. So if a baby has a VSD, will we keep the PTA open? Normally, if a, that's what you got the answer by yourself. Patient with TGA with VSD had 6 to 8 weeks of life for survival. TGA with VSD has 6 to 8 weeks of timer. Okay, within 6 to 8 weeks, you have to do something, otherwise the baby will expire. So 6 weeks तक तो कौन wait करेगा? After birth only, once we diagnose by X-ray and echo and everything, we call the pediatric surgeon. We call the pediatric surgeon. And why you're calling pediatric surgeon? To do the jetiny repair, yes or no? So we'll not go till 6 weeks. We'll call the pediatric surgeon and get this switch operation done or the jetiny repair as soon as. So that's the answer. Okay. Exactly. The patient will have cyanosis, he will have congestive heart failure, naturally ejection systolic murmur and single S2. single S2 sound will be there, in the what you called TG. Okay, transposition of great arteries. Okay, and yeah, so of course, if I have to keep my ductus arteriosus open, of course, PG even administration I will give. I will give PG even, right? I because L prostadil, I want to keep my PDA open. I want to keep my ductus open. I will give L prostadil, which is nothing but PG even analog. Number one, it will keep the now. See this word. Every single word is important. It will keep the ductus arteriosus open temporarily. Please remember, ductus arteriosus open is not just the treatment of choice. It is a temporary, a transient improvement. Only as some time it will be an improvement, not like full life. Okay, it will give us some time to call the pediatric surgeon. Yes, dear, L prostadil, which is nothing but PGE1 analog, which basically helps in keeping our ductus arteriosus open. We will give the by infusion. We will give this drug. Okay. Next, also, yes, there are other options. The emergency procedure is balloon atrial septostomy. The emergency procedure is balloon atrial septostomy, and definitive procedure is nothing but arterial switch. Arterial switch. Please remember there was a MCQ here. The one which I did the switch, no, like this one and this one. So what was that? This is not the atrial switch. You are not switching the atria here. Please remember, we are switching the arteries. This is known as arterial switch. Okay, this is not atrial switch. We are not switching the atria. उनकी arteries को हम जोड़ रहे हैं. Are you understanding? ये भी MCQ है. This also is the MCQ question. People have done wrong. Instead of doing the arterial switch, they have written atrial switch. Okay, so that you should know. So arterial switch we are doing, not atrial switch. And people get confused in PGE1 analog and PGE2 analog also. Please remember, placenta secretes PGE2. PGE2 is endogenous. PGE1 I will give L prostadil. I can give PGE1, but I cannot give PGE2. PGE2 placenta secretes. PGE2 is endogenous. Okay. Has everyone understood this much? Put a like button or please put a comment button that you have understood. Today is the Saturday. What is the plan? What is everyone doing Saturday and Sunday? What is everyone doing? How much syllabus are you going to? Anyone going out for movies? But have a curfew here. Go for movies. Anyone? हाँ, समझ में आ गया? Out. Okay. देवीना, राशि, ठीक है. Hello Karan. Good morning bro. Late आए हो आज, क्या बात? Late उठे थे? Okay. समझ में आ गया? I think this morning classes are good actually. अच्छा syllabus खत्म हो जा. Okay, Rashi will study Dharma. Okay, very good. And I have night duty. Let's go. Night duty. Okay, done. So, okay, now who will tell me in TGA, will you see plethoric lung fields or oligemic lung fields? So, so in TGA, that's what, I told you in a case of TGA that this part is nothing but our aorta and this part is nothing but our pulmonary artery. So when the blood from the lungs enters the left atrium and then left ventricle and then to the pulmonary artery and then back to here, so this part there will be little increased pulmonary blood flow. There will be little increased pulmonary blood flow. normal to high normal to high pulmonary blood flow is there, that you should remember. Little increased pulmonary blood flow you will see. So that is why transposition of great arteries becomes a plethoric lung fields. So remember that. Okay. Devina says she will watch my lectures for the weekend. Okay, that's nice. Finish your syllabus. I would say finish the whole syllabus. That's very good. Okay, so now we have done like Rushkind procedure. Now we know we do in dextro TGA. Jetany procedure or Jetany repair we do in our what do you called TGA. Where do you see Norwood procedure? Can anyone tell me where do we do Norwood procedure? Where do you do Norwood procedure? Have you heard about it? Yes, Norwood is a very important procedure. I have done in my previous classes also. I have told you it is done in HLHS. It is done in HLHS. What is HLHS? Hypoplastic left heart syndrome. In hypoplastic left heart syndrome, we do the what you called Norwood procedure. In the hypoplastic left heart syndrome, we do the Norwood procedure. Right? This is important. Remember, a Norwood procedure is not just one-time operation. 2 to 3 schedules of the surgery are done. Hypoplastic left heart. This is the normal heart, but here this left side becomes totally hypoplastic. So I have to make the left atrium, left ventricle, and the aorta. So it takes around 2 to 3 various timings of surgeries. पहले एक पार्ट करेंगे, फिर दूसरा पार्ट, फिर तीसरा हार्ट पार्ट. Okay, done. That you should do. Done. Okay, how much time? 9:30 we started, no? Oh. Is everyone okay? सबको समझ में आ रहा है? Next topic of choice is nothing but TAPVC. What is TAPVC? TAPVC also, we have done this, is nothing but total anomalous pulmonary venous connection. What is TAPVC? TAPVC is total anomalous pulmonary venous connection. This part also very beautifully we have covered. Total anomalous, the name itself tells. If I make this heart diagram, okay, I'll make the heart here. These are the four chambered beautiful heart, and this is our lungs. Okay, normally the blood from the lungs enters with the help of pulmonary veins. They enters the left atrium. Yes or no? This is normal, right? With the help of pulmonary veins, our lungs, the purified blood enters from the lungs to the left atrium with the help of pulmonary veins. This is the normal phenomenon. This is the normal phenomenon. Okay, and now what happens? So this is normal. Okay, this is normal. The pulmonary veins carry the oxygenated blood from the lungs to the left atrium. Now the topic is total anomalous. Total anomalous matlab totally wrong. What is totally wrong? Pulmonary veins ka connection means, now this is our, what is this? Here we have the superior vena cava. So now the blood which is entering the left atrium. Now what is happening in totally wrong pulmonary veins ka connection? Pulmonary veins, instead of getting connected into the left atrium, they are getting connected into the superior vena cava. Pulmonary veins, instead of getting connected into the left atrium, they are connected into the superior vena cava. This is known as, like, when the pulmonary veins are getting connected into the superior vena cava, this is known as supracardiac TAPVC. Supracardiac TAPVC. Supra means above the heart. Supracardiac. Okay. So there are three types of TAPVC. One is supracardiac TAPVC, one is cardiac TAPVC, and one is infracardiac TAPVC. Okay, there are three types of TAPVC: supracardiac, cardiac, and infracardiac. In a case of supracardiac TAPVC, the pulmonary veins are getting directly connected to the superior vena cava. That is the first point. Now, what happens in cardiac TAPVC? The pulmonary veins now get, instead of getting connected anywhere else, they are getting connected into the right atrium. When the pulmonary veins are getting connected into the right atrium, now this is known as cardiac TAPVC. Is known as cardiac TAPVC. And when the pulmonary veins are getting connected into the inferior vena cava, that is known as infracardiac TAPVC. So can we appreciate, we have three types of TAPVC: supracardiac, cardiac, and infracardiac. In the supracardiac, the pulmonary veins are getting connected into the superior vena cava. In the cardiac, the pulmonary veins are getting connected into the right atrium. And in the infracardiac TAPVC, the pulmonary veins are getting connected into the inferior vena cava. PG entrance question number 1. Which is the most commonest type? Which is the most commonest type of TAPVC? The most commonest type of TAPVC is supracardiac. Supracardiac TAPVC. That is the first PG entrance question. PG entrance question number 2. Where do you see figure of 8 appearance? Figure of 8 appearance on X-ray. I'll show you the picture also. Figure of 8 appearance also, it is seen in supracardiac TAPVC. See, a good student will say TAPVC, but a topper should say supracardiac TAPVC, because infracardiac TAPVC will come as a whiteout lung. Whiteout lung picture. I'll repeat again, we have supracardiac, cardiac, and infracardiac. Only supracardiac TAPVC will have a figure of 8 appearance. How does the figure of 8 appearance look? This is a very beautiful picture, very beautiful picture of the figure of 8, like this figure of 8 appearance. Or you can say like a snowman's heart, like a snowman's sign, snowman's heart, whatever you want to say. Okay, so this is nothing but figure of 8 appearance, and infracardiac TAPVC will have a what you call kind of a whiteout lung. And the most common is supracardiac TAPVC, and which is the most obstructive type of TAPVC, which is the most obstructive. The most obstructive type of TAPVC is nothing but infracardiac. Infracardiac TAPVC is the most obstructive type of TAPVC. Understood? The most common type of TAPVC is supracardiac. The most obstructive type of TAPVC is infracardiac. The most surgical one, emergency one. Like everything is emergency, but the most obstructive one will be a infracardiac TAPVC. This much has everyone understood? Please put a like button or say yes, or you can say yes, yes, that you have understood. Tell me fast so that we can move further. Okay, very good. Zainab, Devina, Rachna, very good. ठीक है, समझ में आ गया? Osama, समझ में आ गया bro? ठीक है, very good, perfect. Yeah, you understood? Hmm. Okay. So yes, so what do you call again we have this motivating quote. Don't compare your progress with that of others. Don't compare your progress with that of others. We all need our own time to travel our own beautiful distance. Very simple and very, very meaningful quote. Don't compare your progress with that of others. So she has covered sir 7 subjects, sir. So my only one subject I have covered, sir. Sir, he's studying so fast. My speed is so slow. Sir, my friend, she studies till 3 o'clock in the early morning, and I feel so sleepy after 11 o'clock. I can't tell you. So, dear, everyone has their own speed, everyone has their own way of studying, and everyone has their own journey. Someone who is studying 13 14 hours per day doesn't mean he's a topper, and someone who is studying only 6 to 8 hours per day doesn't mean that he will not clear. I have very well seen students who are studying for 6 to 8 hours, 8 to 9 hours, very very smart studying, very very smartly they are covering the syllabus, and they are very happy, and they are very good in extracurricular also. I told you one of my like all India all India rank 7. She used to say that every evening she used to play badminton for 7:30 p.m. to 8 p.m., and then she used to study again 8 p.m. to 10 p.m., and then she used to sleep by 10 p.m. and get up in the morning at 3 o'clock and start studying again. So everyone is having their own speed, everyone is having their own pace. So don't compare your progress with that of others. We all need our own time to travel our own distance. तो आपका अपना जर्नी है, मेरा अपना जर्नी है, बस. Don't get greedy, don't feel inferior, and even don't feel superior also. You should never have ego. Be nice, be humble, be kind, be calm, and do your best shot. That is the best way of living. Okay. Yes, okay, Zainab. So don't compare your progress with that of others. We all need our own time to travel our own distance. Everyone has their own way of studying. I'm telling you. I have seen people asking, "Sir, it's only 3 months left. Sir, will I be able to clear? Sir, only January is there. Only 2 3 months left. Sir, should I plan for the next PG, next NEET exam? Should I just wait for 6 months?" No, dear. Everyone has their own way of studying. You never know you get a better rank. It's all about the smart work. It is all about the smart work. You don't have to do hard work, hard work, hard work. Do smart work. No, like the way I'm teaching you, three, four things in one, five, six things in one, like that. That's how it is. So we have covered again TAPVC also. Let's just revise, or let's just understand few important points. Total anomalous pulmonary venous connection. I told you pulmonary veins, instead of draining into the left atrium, they drain into the either into the superior vena cava, either into the right atrium, either into the inferior vena cava, or inferior vena cava is connected to what? Inferior vena cava are connecting to the portal veins or the hepatic veins. Yes or no? Like whatever we have studied, we are just just revising that. Okay. So now, if the pulmonary veins, they drain into the superior vena cava, or that is the most common type of TAPVC. When the pulmonary veins are draining into the superior vena cava, or some book says even a left innominate vein, that is the most common type of TAPVC. Number one. Number two, we have cardiac TAPVC. When the pulmonary veins are draining into the right atrium, that is the cardiac TAPVC. And what is infracardiac TAPVC? When the pulmonary veins are getting connected into the hepatic veins or portal veins or inferior vena cava, that is the infracardiac TAPVC. When the pulmonary veins are getting connected into the inferior vena cava or hepatic vein or portal vein is the infracardiac TAPVC, and it is always obstructive. It is always obstructive. That's another exam question. Okay, this is a figure of 8, very beautiful figure of 8 appearance. Figure of 3 appearance you see in coarctation of aorta, and figure of 8 appearance you see in supracardiac TAPVC. I assume that we know these all points, we understand. Okay, very, very, very important picture. Infracardiac TAPVC appear as a white out lung. I was telling you white out lung. So this is the whiteout lung. Can we see? Normally a lung should be there. See, this is like one lung and this is like one lung. This should be the heart, right? So this should be black, right? The normal lung, what happened? It should be black, no? Like that. It should be black, right? This one is nothing but a whiteout. Can we appreciate yes or no? Put a message in the comment section. दिख रहा है कि सफेद सफेद है लंग, वो black portion ही नजर नहीं आ रहा मेरे को तो. So it's a whiteout lung. White out lung. And what are these? ये what is this matchstick appearance? समझ दिख रहा है माचिस की तीली की तरह छोटे छोटे क्या हैं ये जो ये माचिस की तीली की तरह क्या है? This matchstick appearance is nothing but what is this? This is nothing but air bronchogram. Air bronchogram. Now, what is air bronchogram? Again, I have told in my HMD class, hyaline membrane disease. We have done a 1 hour lecture. In that one, I have shown you multiple pictures of air bronchogram. What is it? Why does it happen? And this and that. So right now in this class, only I can tell you that this is a picture of white out lung. Number one. Number two, white out lung. It is seen in hyaline membrane disease. Yes or no? Have you heard of hyaline membrane disease, which is also known as respiratory distress syndrome? More the baby is premature, the surfactant, there's a surfactant deficiency, yes or no? Surfactant basically helps in formation of the, it helps in formation of the lungs, I would say. So when the surfactant deficiency is there, my lungs will not form properly, and that will lead to a whiteout lung. So whiteout lung is seen in condition where my baby is premature or preterm and surfactant is not formed, and that is known as respiratory distress syndrome, or also known as hyaline membrane disease. Whereas what you called other than HMD, you see in infracardiac TAPVC. Infracardiac TAPVC also you see a whiteout lung. Even a massive pericardial effusion. Even a massive pericardial effusion also you can see a whiteout lung. Massive pericardial effusion you can see a whiteout lung. So these are the three important differential diagnoses of whiteout lung: hyaline membrane disease, infracardiac TAPVC, and massive pericardial effusion. There are 5 6 others also differential diagnosis, but those are not important for the right now for the exam purpose. Okay, this TAPVC patient, when does the onset of congestive cardiac failure happens? So normally by 4 to 10 weeks of life. Normally by 4 to 10 weeks of life, you will have a what you call onset of the CCF of the failure. Now listen everyone, I want you to make a chart, okay? Like see this also 4 to 10 weeks of life. What we were studying in the TGA, we were studying that TGA, isolated TGA, when it will go into failure, who will tell me? Isolated TGA when it will go into failure, and TGA with VSD when it will go into failure. Who will tell me that? Tell me fast. We have to link and study, dear. That is the thing. If you know how to link and study, then only you will understand. The very important slide. Number one, isolated TGA ka baby when it will go into failure or when it will go show you symptoms. TGA with VSD will show you when, and now the third part is TAPVC patient. TAPVC patient will show you when. Exactly. So TGA alone, I remember it was first week. In the first week of life, basically, it will show you what you call the failure features. TGA with VSD, I told you 4 to 8 weeks. Yes or no? I told you 2 months. 2 months. And here also same 4 to 8 or 4 to 10 doesn't matter. It's almost like same. Okay. So yeah, that's what. So isolated TGA will show you symptom within 1 week. TGA with VSD will show you the symptoms in what you call roughly around 4 to 8 weeks. And same goes with the TAPVC also. It will show you like a supracardiac TAPVC. It will show you in 4 to 8 or 4 to 10 weeks. Please in your notes write that. This only will give you the marks. Okay. For example, S2 heart sound. I told you in the last class also. What happens to S2 heart sound in ASD, VSD, and PDA? In ASD, there is a wide fixed split of S2, wide fixed split of S2 in ASD. In VSD, you have a variable, what you call split of S2, wide variable split of S2, and in PDA, you will have a paradoxical splitting of S2. Why this happens, again, if you're a newcomer, watch the previous classes. I can't tell everything in one class because each point it takes half an hour to explain. So go to the previous ASD, VSD, PDA classes before the session gets logged, before the session gets private. Watch the all videos and finish your notes, update your notes. So in atrial septal defect in ASD, the H2 heart sound will be wide, this one wide fixed split, and in VSD it will be wide variable split, and in PDA it will be a paradoxical splitting of H2. That is one part. ये सब एग्जाम क्वेश्चन है, these all are exam question, इसी के नंबर मिलने हैं, ठीक है. Okay, very good. Yes, right. And that's what, so onset of CCF in a case of TAPVC supracardiac, it will be 4 to 10 weeks. And obstructive TAPVC. Obstructive TAPVC, again, it will show you the symptoms of congestive cardiac failure in 1 to 2 weeks. So can we understand isolated TGA का patient एक हफ्ते में feature दिखा देगा. Obstructive TAPVC का patient, obstructive TAPVC का patient 1 to 2 weeks में दिखाएगा. So 1 week, 1 to 2 weeks, and roughly 4 to 10 weeks. Within 1 week, the isolated TGA patient will show you features. 1 to 2 weeks, the patient of obstructive TAPVC will show you the features of CCF. And 4 to 8 weeks, or I would say 4 to 10 weeks, our supracardiac TAPVC and TGA with VSD also will show you the features. तो ये सारे अच्छे अच्छे पॉइंट्स हैं. कर लोगे तो भला होगा, नहीं करोगे तो बाय बाय टाटा हो जाएगा, ठीक है. That's it. So that's what I think. Yeah, it's so that's what. And remember again, this is about life. जिंदगी में सबको यही दिखता है. This is what we see. Success. Like we everyone say that this fellow has a big house. This fellow has a big car. This fellow has a big property. This fellow has a big huge fan and crowd. Even people ask me, you are so young and you have such a huge crowd and this and that. So success, success देखने में बड़ा अच्छा लगता है. But what is the behind part? Can we see that this like a that this उसको क्या phenomenon बोलते हैं, disease कुछ बोलते हैं ना community medicine में, Osama? Iceberg phenomenon, right? I think something like iceberg phenomenon. Like this much disease is in the community and the reality is seen only this much. So that's what, this is life, right? So no one understands how much consistency, how much hard work, how much risk, how much competition, how much discipline, how much courage, how much criticism, how much failures, how much rejections we get, and then we get success. And same goes to your story also, same goes to my story also. Being a student also, so much of hard work, so much of consistency you are doing, so much of risk you are taking, so much of late night work hard you are doing, so much of courage you are showing, so much of failures and criticism you hear from people, and still the one who will pass all this only will get success. Success doesn't come free of cost. It doesn't come free of cost. If it comes free of cost, you will never understand that this is success. After pain only, that thing which comes, no, that only is success. Yes, Mani Prakash is right. Iceberg phenomenon in community medicine, there was a topic of 5 marks question for MBBS. What is iceberg phenomenon, right? Very good. Next, there are only 3 points of tricuspid atresia. Tricuspid atresia, right? What is tricuspid atresia? This is the our tricuspid wall, which is between the right atrium and right ventricle. Tricuspid atresia. What is atresia? Atresia is abnormal narrowing. Stenosis means fully block, but atresia means what you call abnormal narrowing. So congenital absence, I would say, of the tricuspid wall. In tricuspid atresia, there is a congenital absence of the tricuspid wall. Then what happens? So what will happen? There will be a hypoplastic right ventricle with absence of inflow portion of the right ventricle. Very nice. So this is our what you call tricuspid wall. And what happens in tricuspid atresia? They are saying that there is congenital, like there's a hypoplastic. So it's like this much only. There is a hypoplastic right ventricle. Right ventricle bana hi nahi hai because there is a congenital absence of the tricuspid wall. So there is a hypoplastic right ventricle, number one, with absence of inflow portion of the right ventricle. Do you agree with me? Will there be an absence of inflow blood or to the right ventricle? Of course, because there is a tricuspid atresia, है ना? Very good. So then what will happen? That's what the blood can't flow. The blood can't flow from the right atrium to right ventricle. Yes or no? So in tricuspid atresia, the blood can't flow. The blood cannot flow from the right atrium to whatever that hypoplastic right ventricle is there. The blood can't flow. So for the survival now, for survival of the baby, what do you need? Which defect you need to be open, right? For so for survival of the baby, either you have to open a ASD, or you have to open a VSD. Are you understanding? For the survival of the, see, when the blood cannot go from right atrium to right ventricle, how the baby will survive? So you have to open an ASD, right? You have to have some defect, I would say. You can't open an ASD, but that's what again I'm saying. All the congenital heart defects are not isolated. They are always associated with other heart defects, because when the defect of the tricuspid atresia was forming, when the blood cannot only go from right atrium to right ventricle, there has to be some other defect. There has to be some other defect. For example, ASD in this case. Now, please remember, now ASD is a left to right shunt, okay? But imagine, remember now, in this defect, of course, it will be from right to left naturally, because blood to ja hi nahi payega na. And even though it is a left to right shunt, there's a tricuspid atresia, right? Tricuspid stenosis or atresia is there. The blood cannot go only from left to right. It is always from right to left in a congenital abnormalities I'm talking about. Are you understanding? Yes or no, Pooja? Yeah, very good. So the blood, number one, blood cannot flow from the right atrium to right ventricle. Number two, for survival, we need the following defect. Which defect do we need? For again, for flow from the right atrium to left atrium, either I want a patent foramen ovale, or I want a atrial septal defect. Do you agree with this me? Yes or no? है ना? Naturally, we need some patent foramen ovale or a ASD I need. Number one. Number two, for flow from the left ventricle to right ventricle, right? I told you, even though there is a tricuspid atresia, but little bit right ventricle is there, hypoplastic right ventricle is there. Whatever by mistake some blood has come, I need either a VSD, I need either a ASD, or I need a foramen ovale, which is the S shape, which forms fossa ovalis and this and that. So that's what. So when the blood will go too much here on the left side, because right side there is no option only to go to the blood, so left side it'll go, so lead to left ventriculomegaly, you can say that, and left axis deviation in the ECG. Okay, hello pancake, good morning. बड़ी जल्दी आई हो, बहुत जल्दी आई हो. So left ventriculomegaly and left axis deviation in a case of ECG. Okay, very good. That's what. So I think we'll finish it up till here only. Epstein anomaly we'll talk in the other class. It's already what you call 60-70 minutes talking. Has everyone understood this much? Let me know. Okay. So truncus arteriosus and this one, what you called Epstein anomaly, I'll talk in the next class, because this class already has crossed 60 minutes. So it's like 70 minutes are over for this class. Very good, you woke up just now, Pancake. So I request Pancake, please later watch this session again. It's a very important session which we have covered, and that's it. And thank you so much for the participation. And tomorrow we have a class. Wait, let me check. I have written in my notebook. Tomorrow is Sunday. I'll come back home in the morning, and then we have lot of classes. Let me just tell you, like, be updated on the what you called our YouTube channel, and also at the same time tomorrow we have three classes on cardiology. We have to finish the cardio. So let me, tomorrow what time we have the class? tomorrow आजकल तारीख क्या है कौन बताएगा? 16th. 16th, yes. Tomorrow we have a class at 11 a.m. Then we have a class at p.m. and then we have a class at 4:30 p.m. So we have three cardiology classes tomorrow, and we'll cover the other important sessions also, like truncus arteriosus. Tetralogy of Fallot is a very important topic. TOF has to be told in depth. And okay, test. Fine, I'll take in one of these session. I'll take a test. I'll take a test, surprise test for you guys. Could be cardiology, could be anything else also. किसी भी एक session में I'll take a test of yours. Tomorrow, three sessions. Make sure you guys are free. 11 a.m., 2 p.m. and 4:30 p.m. we have a class. It will be there on this YouTube channel only tomorrow. Yeah, 3 hours, 11 a.m., 2 p.m., 4:30 p.m. Okay, and Pancake and everyone who has come late, please what you called watch the previous cardiology videos. Watch these videos. They are like very fruitful. It will be really helpful for you. Okay. Yes, no, the Pancake tomorrow's class will not be on the Unacademy app. Tomorrow, these three classes will be there on the YouTube channel only, and YouTube channel पे ही रहेंगी classes. Okay. Or before leaving, I would like to thank Dr. Shubhangi. Now she shared this wonderful quote to me. Thank you so much, Shubhangi. So the last quote for today is, because this is the only today's class we are doing it. The last quote is, everyone wants happiness, nobody wants pain. Everyone wants happiness, nobody wants pain, but you can't have a rainbow without a little rain. Very, very, very cute and very sweet. What do you called this one quote we have, which Bhangi shared. So everyone wants happiness, nobody wants pain, but you can't have a rainbow without a little rain. So happiness will come, sadness will come, pain will come, excitement will come, cry will come, everything will come. So these all are a part of life. Don't get carried away with happiness. Don't get carried away with success, and most importantly, don't get carried away with sadness also. Some people takes 1 month to get over depression. Some people takes only 1 week. Some people takes 1 day just to come out of depression. So it all depends on your willpower, your focus, your way of living life, your way of analyzing things, that will make you a better person. नो कहते हैं ना, भगवान ने सबको एक जैसा ही बनाया है. कोई बंदा हफ्ते में ठीक हो जाता है, कोई बंदा एक दिन में ठीक हो जाता है, किसी को 6 6 महीने लगते हैं ठीक होने में. So it all depends on the willpower and how much experienced person you are. Okay, so thank you everyone. Differential cyanosis and reverse differential cyanosis अब कल पढ़ेंगे, क्योंकि मुझे भूख लगी है और घर पे आलू पूड़ी बनी है. I have breakfast, and kal I'll tell you about the differential cyanosis and reverse differential cyanosis. And I had a okay, homework I have to give you, which always what do you call this one pancake only reminds me. This is the homework for today's class. This is the, this homework I'll be discussing tomorrow. Where to look for pre-ductal oxygen saturation in a case of PDA in a 3-minute born infant. This is the homework for tomorrow. Take a screenshot of this question, and this is the NEET 2019 question. Where to look for pre-ductal oxygen saturation in a case of PDA in a 3 minutes born infant. Very nice question is this. Tomorrow I'll be discussing about this, and the another question of differential cyanosis and reverse differential cyanosis also. I will talk about this two things tomorrow. These are the two homeworks. Okay, so very beautifully, you guys should read this and get back to me tomorrow. And that's it. Yeah. Yeah, some people take 2 years also. So you took 2 years to come out of depression, pancake. Yeah, so these three times please remember, and see you tomorrow morning 11 a.m. tomorrow. Bye bye. Take care. Bye 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 pancake. Bye everyone. Bye Rachna. Bye Osama.